Good morning, everyone, and good afternoon to Europe and London. I'm calling from New York, and welcome to the CogX Global Leadership Network on health. And today we'll be talking about is Web 3.0 the medicine healthcare needs. I want to thank CogX for their generous patronage and their organization. And I want to encourage all the attendees to hashtag CogExtras for this fascinating conversation. My name is Dr. Alex Kahana, and I am the founding member of BTblock Health Group. And I have been, besides my clinical practice in integration of these type of disruptive technologies for the last 15 years. I'm excited to present a all-women panel today, a diverse and dear friends from all over the world that are with us. And I'll start with Dr. Ali Lovis. Please present yourself. And then afterwards, Dr. Samantha Nazareth and Irene Kiwia. Go ahead.
Oh, yeah. Good morning, everybody. So, Dr. Ellie Levies, and I've been working in emerging technology my entire career. Sorry, having a little audio difficult. So, I've been working in emerging technology my entire career, dual board certification in pediatrics and clinical informatics, and led U.S. healthcare blockchain for Ernst & Young for the last year and a half, and now I'm an advisor to BTblock.
Excellent. Thank you, Ali. Go ahead, Samantha.
Hi, everybody. Very excited to be here and join in this discussion. Thank you for the host for putting this event on. I am a practicing gastroenterologist in New York City, and I've been in the tech space now for, I would say, like 3 years.
Thanks. And Irene.
Hi, everyone. Such a great pleasure to be here. I am a tech entrepreneur that is based out of Africa, and my passion is looking for solutions that will empower women across Africa.
Thank you. Thank you so much, ladies. And just so the audience knows, we have calls here both from New York and Irene, where are you? Are you in Nairobi or?
I'm in Nairobi, Kenya.
Excellent, excellent. Well, I think that I encourage all, first of all, I encourage all the audience and listeners to use the Q&A button and ask questions as we move forward. But I would want to start, and perhaps I'll start with Dr. Lovis. Why did you get into digital health and at all? I think that would be as a practicing physician.
Sure, and it goes way back to when I was even an undergraduate and doing some work in computer sciences there and databases. And it just seemed to make logical sense to the way my brain thinks and organizes things, that much of the data we collect could be put into databases. And then we can draw information from those databases. So I started before people even thought physicians would use computers. And I was actually told physicians will never use computers, like give it up. But they say I persisted. So that's why I did it, just for efficiency and access to information for the patients that I was taking care of. I practiced for over 20 years. It was quite enjoyable the way we first set it up. Now I saw digital electronic health records start to cause some burnout for physicians, and got much more interested in human-centered design and user interfaces. And so making sure that that's a part of the practice now. So when we talk about digital, we make it usable and an enjoyable, if not delightful, experience for our end user. And that could be the physician, that could be the nurses, that could be technologists, right? It could be patients. Everybody has to be able to enjoy the experience.
Fantastic. So it almost sounds like, Ali, you were in with the birth of digital and still remember the analog and how things were written on paper and pen. Samantha, could you tell us a little bit about your kind of diving into the digital? It doesn't seem that you were writing things with pen and pencil. So what is your approach and why going into digital?
I actually, at some point within my training, I was still functioning on paper charts, believe it or not. But yes, so I would say, everybody's journey is a little bit different. But when I took part in my career to say, yes, I want to become a doctor, and basically I signed into an 8-year combined undergraduate and medical program when I was 16 years old. And then fast forward 20 years later, when I was done with internal medicine, I did 2 fellowships. That was a good 20 years later. The world that I knew had changed. The world that I was living in back when I was 16, and then 20 years later, when I was actually done and ready to practice, was completely different from the advent of smartphones, and then everything just kept building and growing exponentially so fast. And I was able to experience that in different practice settings. And I just said to myself, okay, so I don't think it's a big surprise that doctors hate the electronic medical record. There's been a lot of grief with it. And I didn't want to be a complainer, basically. I wanted to be part of a movement and part of the change that was happening, that I was seeing all around me. And that was my decision to go and learn more about tech, emerging tech, and the things that we'll be discussing later. I didn't want to be left behind. That was my real honest answer.
Very good, very good. Irene, you heard already this morning 2 doctors complaining that the electronic health records are burning them out and they're unhappy, and we need to make minimal, lovable products. So tell me a little bit and tell the audience, your journey. Why did you go into digital health, and maybe a little bit about your current project of your electronic health record that you designed.
So my journey towards digital health came from my passion to empower women, which is a bigger journey that started over 14 years ago, when I wanted to come up with solutions that will empower women in Tanzania and give them tools that they need to create wealth for themselves. And when we talk about wealth creation, we have to look at different components, health being a very critical part of it. So in that journey, in the last 5 years, when I started looking at how to use technology to leapfrog some of the solutions that are around different areas that will empower women, health became a no-brainer, as a project that I have to engage in so that we can solve some of those issues. So 3 years ago, we did a lot of research in East Africa, just to understand, when we look at empowering women, what are the critical things? Obviously, financial inclusion is one of them, because it's centered around wealth creation, but access to health, is also a very critical part of it, because we do not have good infrastructure in Africa for a lot of the population to access health. We are talking about being, so backwards in some of the, not just infrastructures, but also having access to enough doctors and so many other problems. So it was inevitable for me to look into getting into this journey. When I met my partner, a co-founder who had a very big dream around creating a health project, I had to jump in. So what we are rolling out in Africa now is a solution called Afya Record. Afya is Swahili and it means health, record obviously, so health records. And what we're trying to solve is the issue of access to quality health data and how we can use this health data to create better and quality healthcare. in different variables, from access to doctors remotely and virtually, to access to information, to mobility of data and what that means, given that a lot of African population is centered around rural communities, with no infrastructures, where people have to walk miles and miles to access health facilities. So we are very excited. We went live around April, just during the mid of COVID, and we are currently rolling out in Kenya with various hospitals, and it's quite an exciting project.
Yes, thank you.
I love your inspiration, by the way.
Indeed, Irene.
Well, people thinking today.
Yeah, thanks, Irene. I agree. I second Ali, and I'm sure Samantha too. And I encourage the audience to look at Afya Rekod, REKOD. So the Swahili health record that will be in the whole small continent of 1.2 billion people of Africa soon. But saying, I'm hearing from all three of you using digital tools as the ability to empower. Irene, you mentioned women. In general, I'm sure we're talking about everyone. Ali, you're familiar with what's going on in the United States. You're familiar with privacy laws, with legislation, with things that are extremely heavy and friction full. Can you share a little bit with the audience, both in I would say the more established economies? How does this play with data and empowerment work at all? Do we own our electronic record? Do we own our data? What's going on in places across the U.S. and Europe?
I think you hit on the complex tensions that are within the system. So do we own our data? As a patient, do I own my data? One state recognizes that you own your data. Everywhere else, they don't really say you own it. They say you have the right to access to it. And then there's that tension with the tension of the healthcare systems facing fines and violations if they release your information incorrectly or for the wrong purpose, or it gets used for the wrong purpose. So there's that tension. And then put in the business tension of data. I'm really interested in data, and our data is the new oil. So they want to keep the data. So now they have financial incentive to keep it. They have some tension with don't release the information so we don't get fined. And then we have patients who are like, about me, nothing. I need my data. I'm not getting what I need out of the health system. I want to take my data elsewhere. Maybe I want to put it into an algorithm that can look and say, hey, this is where you could get your best care, or this is the best treatment. And so people are feeling stymied. So I think that's the current tension in the United States. And we have strict privacy laws, and then we just passed regulations on information sharing. And it's when those regulations for information sharing go into effect and you start getting fines for not sharing, maybe we'll see the pendulum swing a little bit. At the same time, we're working on ways to make it fair for everybody. That the patient gets to say, share my data with this organization, person, for this reason, and we can actually tag that data that has consent for that purpose, that is controlled solely by the patient. And likewise, that gives the organization that releases the information audit log of this is who we released it to and for what purpose. So we can protect and help both sides still advance the movement of data for quality care, to Irene's point.
Interesting. What you described sounds, of course, very, very different than what Irene is describing and what she is working on and developing. Samantha, you were talking about this new world, and Ali mentioned, this ability to own your data and portability and walk with it. Can you explain to the audience a little bit what self-sovereignty is, and maybe explain, is there a technology out there that can allow this self-sovereignty? How would this new world look like in your eyes?
I'll start with a story because this is a story that I feel like as a patient and a doctor, perhaps we both have experienced it at some point. Um, I broke my foot at one point in my life and ended up in an urgent care to basically get this matter taken care of very quickly. And at the point, I didn't know where to go. Had an x-ray done and was told to follow up with an orthopedic. And of course, then the question is, well, how do I get my information from that urgent care? So what happens is you get a CD. And I've been on the other end when I've received CDs from patients, and it's quite embarrassing because I don't think a lot of people realize that the CDs can't open anymore in various computer systems and softwares. So basically, anytime I move care from one place, system, state, if it's not in the same, it's even further than just not being in the same electronic medical record. It's really a system or a practice. That data doesn't flow with you. So I have my CD, I take it to an orthopedic. They can't open that CD up to see the images that's important for them to make a clinical decision of the fracture. So I'm left with, oh my goodness, like I have to call the urgent care to send the actual report, and that may take 2 days. And you see how much stress, drama, all the like that happens with just getting my own data from one place to another. And it wasn't even like a second opinion. This was something that was recommended, right? So I think that's a journey that I feel like everybody has experienced where the data doesn't flow with you, specifically health data or medical data, especially if you moved. It's almost like if you moved, change doctors, even change employers, then you're stuck with how do I transfer this data around? So on the flip side, if it becomes self-sovereign, all that means is that now me as a patient, I have all of that data held to me. So it's not sitting in some urgent care in, let's say out of state, a state that I don't live in. So I live in New York City. So I'll pick, maybe Texas or California. I have it with me on my phone. So wherever I go with my phone, everything is held here. And I don't have to worry and stress out on the phone like, hey, can you send my medical records? This goes with me along with my health data to any provider or doctor that I need care from. That's really, it's the ability to be able not only to access someone, but to have your data that's important for a medical provider to make a clinical decision that's best suited and personalized to you. As a doctor, I need a lot of information. Everything is always in context. So the more information that I have, albeit, sometimes it can be overwhelming, it's an important factor in making a personalized treatment plan for the patient that's sitting in front of me.
That's amazing, and I'm sure that a lot of people that are listening now are kind of asking themselves, how does this even happen? What is the technology behind it? What is the magic? So Irene, without going too much into the technological details and turning this into a tech talk, what in general are the technologies that Afia Record or in general self-sovereign electronic health records use in order to allow what seems such a elegant and easy solution?
Yes, so well, I completely resonates with what Samantha just talked about, because the case for Africa is the same. In the last 2 years, and I have been in over 20 hospitals or more, and because we don't even have that culture of having a family doctor or, so wherever you are, whenever you feel sick, that's where you go, access healthcare. And, we're talking about someone who can afford to access that healthcare, because the rest is real. Most of the Africans don't have the same opportunities. So what we have done with Afya Record is we've built an AI-driven platform that has AI modules to allow for quality data collection and quality data collection from multi-points, starting with your mobile phone. You know, we say at Afya Record that treatment happens at the hospitals and healthcare happens when you're out of the hospital, because you're treated and then you still go home and continue to treat yourself, and you have to do all these things, you know, that are supposed to add value to your health. But that information is all missed out, you know, let alone, you know, the fact that there's a lot of, yes, hospitals do have data, but it's in silos, you know, it doesn't move from one hospital to another, it doesn't follow the patient, and it's not even live data, it's static data, you know. So yes, the information is there, but what does that mean, and how can healthcare providers use that data to understand diseases, to understand patterns, you know, to predict, to see, you know, for example, something that happened in Tanzania, was it last year? There was a dengue fever situation, but it took, you know, a couple of days before we understood, you know, yes, it was dengue fever and this is what we needed to do. So our solution, like I said, is built with AI technology, AI modules. But what we want to achieve is not just have the best interpretation of data, being able to predict diseases before they become a pandemic, or before they become a bigger problem. You know, at any point in time, if 100 people or 500 people within a certain geographical location report the same symptoms on their Afya Record platform, the system is able to pick that up, and we're able to see that there's a problem there. So it's very simple. It's accessed as an app, you know, for general users. It's accessed as a USSD portal for what my co-founder calls a dumb phone. I call it a feature phone. And you know, these are phones that, you know, do not require data to use, which is what a lot of people in Africa use. And it also has a portal access for hospitals and healthcare facilities. So it provides an opportunity for different healthcare implementers to come into an ecosystem and support that one individual with different touch points, you know, whether it's, you know, accessing a practitioner or remotely, or it's accessing information, you know, with so many different resource portals. You know, we're really unable to know whether that information that we're seeking and Googling on the internet is accurate or is coming from a professional or not, you know. So with Afya Record, you know that this information has been verified and is coming from professionals. And whether it's also at a later stage allowing for a greater participation from doctors from all over the world to provide healthcare support to Africa. But even at a very basic level, you know, we have a lot of doctors who graduate every year in different universities in Africa, but we don't have enough health institutions to provide employment for these doctors. So with our platform, you know, we are able, in partnership with existing hospitals, to provide telehealth, you know, where now more people have access to doctors. So it has amazing technology, and we're building it and evolving it. For example, when we were planning to launch around April, the reason we launched in April was because even though we were programmed to launch in September, COVID gave us that push. Say, hey, we were building for things like this. So how can we, you know, go to market quicker? And on the platform, we've integrated a COVID solution that can support, you know, organizations and institutions, you know, not just to monitor and manage patients remotely, but to also we've created a digital COVID certificate, that is tied to mobility, that will show you how people are moving, to a symptom tracker that will allow for people to share their symptoms. Maybe there are some missing information, because in absence of us having access, imagine if we knew what every patient who has suffered from COVID has experienced, and we had that data in one place, what that would mean, or something like that. So yes, that is what we're working on.
Oh, it's fascinating. You mentioned a lot of things, and I want to ask both Ali and Samantha about those things and technologies. But clearly AI, artificial intelligence, and machine learning is a big game changer. Of course, now that I have you on board, my Google doesn't stop thinking that I'm a woman from Africa, and they're sending me all kinds of ads, to buy products. But the point, and this is for Ali, is this whole concept of healthcare, treatment at the hospital, healthcare at home. How do you see this kind of pan out? Telemedicine, telehealth. What are your thoughts on that?
Well, I started taking notes furiously on a couple of things. When we talk about the phone that the people use, you say it's a feature phone that doesn't require a data plan? Is that what you're saying?
Yes, it doesn't require internet access.
Right.
So, go on.
So that's so important to be able to have that technology, because the last thing we want to create in the United States or any healthcare system is this digital divide, that it's only the people that have smartphones with internet access and data plans that can access your wonderful technology. So that's the first differentiator I heard, like from Africa to the US, like that. And then the other thing I'm listening and going, are data privacy laws handled in Africa a little bit differently? Or is it because it's a self-sovereign tool, these patients say, we want our data contributing to AI so we can get better quality care? And those are two vastly different paradigms where you're operating than what we have. Those are my thoughts that jump forward.
Well, that's great, Ali. And maybe for the audience to explain, because your expertise is really into privacy. And can you talk a little bit? Irene mentioned AI, but could you talk a little bit, for example, on different technologies that help privacy and that allow this portability that you talked about? Maybe I'll talk a little bit about blockchain, so people will that maybe heard a little bit about it, what that is all about.
Sure. First thing I want to clarify about privacy is privacy doesn't mean my information is locked down. It means I have a choice about what happens with that information. I think that's the intent of most privacy laws, that companies aren't just taking my data without my knowledge and using it. So specifically in healthcare, it's sensitive medicine, but the laws are I have the right to access to my data and do what I want with it. So we'll start there. And again, we talked about previously about the tensions. So let's take a tool like blockchain that will enable that metadata tag on our data, where we have an auditable trail of where that data goes, who's using it for what purpose, and to Irene's point, it's self-sovereign. So maybe I was comfortable sharing my data for a certain point, and then I just said, no, I don't want to anymore. I can withdraw that. Data doesn't get being used over and over again without my permission. So that's how we see blockchain consent coming from. It's patient-centric. I don't go in and I sign the hospital's consent forms. They get the consent from me. And I can also withdraw the consent. I don't have to go to them to do it. I do it. And it all is controlled. And ideally, it would be controlled on those phones. We need some of those feature phones in the US. Sure.
Thank you, Ali. And I want to continue with Samantha because I know that you practice actually both in the U.S. and in the African continent, and you almost have kind of that insight of I know how it is in New York City, and I know how it is I think it was Tanzania, right? That you said that you practiced there.
Yes, of course,
So
worlds, right?
Small
so
world,
so
even virtually.
so how do you see the similarities and the differences between the systems or the application of technology in those two systems?
I think at the very heart of it, when someone is sick, they need access, right? That's where at the foundation of it all, someone has a need, whether it's urgent or non-urgent, it has some sort of health need that they need someone else to care for and actually take action. And depending on where you are in the world, finding that person can be very difficult. Like Irene said, when I was practicing in Mwanza, it's actually a very small area in Tanzania, but there wasn't much by way of opportunities to find care. And even I had practiced in another location outside of Africa, and I would see people traveling a day's worth on various modes of transportation just to see, Ali, you would love this, to see a pediatrician. And the whole family would come, and that access issue is huge. Imagine what you can give back a day of someone's life who's living in these rural, underserved areas. I mean, that's life or death for some people. That's money for food that you're stripping away simply for traveling to access care, whether that's urgent or non-urgent. We all have to have access. So by means of that, that's what the beauty, Irene, you were mentioning. Now you have a platform that can link doctors who are hungry, that can't get employed by institutions, but they do want to provide care to those people that are so far away and have really limited options, and link them together via telemedicine, as one example. I think at the very heart of it, that bridges that gap. We're not all fortunate to be living in cities with multiple availabilities of physicians and the like. That's just simply not the case around the world. And so just having that point of contact be immediate, of patient and doctor, boom, that's huge. That's really big because, like I said, that gives somebody, a family, the opportunity to do something else with that day that they would have taken out to travel long distances. And God knows how dangerous, the travel is as well. So to add that as a layer of complexity, I think that's the beauty of digital health.
And can I add, in the United States,
Yes, please, Ali.
we're
Go ahead.
still an issue in the rural communities here, especially when I have to get to a specialist or I have some rare disease. I can live in a wonderful community. I live in a wonderful healthcare community, and I do. Yet I know one of my friends who needed a specialist with a very unique disease. How fantastic. She picked up the phone yesterday, talked to that center that was in Boston, and had an appointment. She's going to have an appointment today via telehealth. So that instant access to not just care, but now the most personal matched care for you. There was times when, as a pediatrician, I had to send people out of the area for certain illnesses. I'm like, I got to send you to Cleveland. Imagine they don't have to travel to Cleveland anymore. But here's the best care, and that doctor is in Tanzania or Tanzania, I don't know, however we pronounce it. And they get to access the very best care, because that's where the data tells us that's where they have the best experience and the best outcomes. That's where I want to go.
It totally resonates. I remember when I was back professor in pain medicine in Seattle, and I would have people from faraway places, from rural Montana, Nebraska, Idaho, come all the way to see me. And when we started using webcams and create this, virtualization, it was a huge, big thing. I wanted to segue with that to Irene and ask, virtualization, of course, is one thing. What are your thoughts on it being a tool for education? Teaching families. You were talking about empowering, mentoring, adding family members to be part of the healing process. I don't know, even using surveys. Tell us a little bit your thoughts on what Afia does in that.
Actually, that's what I wanted to say when Ali was finished talking, because I mean, the whole point about health is also just knowing what to do and, practicing best practices, for lack of a better word. So think about Africa, yeah, where there is a lot of illiteracy, and there is a lot of, lack access to information. Just basic information that we take for granted because we can either go on Google or we can have these discussions, right? So some very basic information that could help prevent diseases, that could promote families, to adopting healthy lifestyles, everything from eating balanced meals and providing the right nutritions for our children, from mothers being pregnant to how we raise our kids to prevent things like stunting, which is actually a very huge problem in Africa. So, and what that means if we fast forward it, to later, you've gone through this cycle of not having any information and just, surviving, living your merry, happy life. So that is a huge opportunity for us to use Afia Record as a tool for information, information that will prevent, some of these issues that, we have to provide treatment for. But also let's talk about training. You have all these dispensaries and micro hospitals, mini hospitals, not even hospitals, dispensaries or clinics that are in the rural communities where they're in the dark. Again, how do we train? There are so many things that happen every day. We discover new things. Science is not sleeping. There's new discoveries, there's new information. How do we transform this information into the rural communities, the healthcare people who are in the rural, so that they're also able to provide the latest solutions, to treat some of the issues that they're facing every day. So access to information is one of the things that Afia Record platform is working to solve, and this is information directly to patients and individuals, and information to healthcare fraternity in terms of training, in terms of providing latest and up-to-date resources so that they're able to serve better.
This is fascinating. The whole idea of health literacy and how that is important to maintain the wellness of our community and prevention. I want to jump to you, Samantha. You speak a lot about prevention and healthy lifestyles and biohacking. How do you see technology kind of, go into that new world that you're describing, where people are a little bit more responsible, not just consuming health services, a pill for every ill and a test for every test, but actually taking control over their well-being, so to speak. What are your thoughts on that?
When Irene was speaking, I was thinking of when I was practicing. I've practiced in 3 countries outside of the US. what I would have loved to have had at that time were things that I'm seeing now in the wearable space and even the remote monitoring space. Now there are digital stethoscopes, there are digital ultrasounds, all of these things that will eventually be at the hands of the consumer or the patient, right? I don't specifically need to interpret that data. So it gets, it takes a couple of steps that you need the technology to be there. So the remote monitoring capability, and someone to interpret it, maybe a technician or a physician. And then even beyond that, there could be an algorithm of sorts that interprets that for whoever uses it and doesn't actually need to see a doctor or go to a hospital. That's where we're headed, where there's all of this rich information, but it will be at the hands of the user or the consumer. And that's where I see in the biohacking space and the wellness space is I want my data. So at the very first level, I don't want it stored somewhere that I have no access to or don't have permission to. It has to be data that's relevant to me and my own needs. So hence, I will buy or have access to specific wearables that I'm interested in that data. And then I want a great interpretation of that. Like I want some actionable steps. All right, this is great, but now what? And I actually saw this in the microbiome space where the technology, because of DNA sequencing, it became so good that it was actually affordable to have things like a microbiome sequence from the gut. But then the next step was, what am I supposed to do with this data? Reports of 13 pages of all these bugs that I've never even heard of half of them. I never mind pronounce them, but I have this, and then it's on both sides, the patient and the doctor. What am I supposed to do with this data? It has to come to the next level of interpretation and actionable steps on that data. That's why it's Irene, what you mentioned for Afia Record really resonates, because you need a place to actually house the data in order to make sense of the data and have action steps, have something that makes sense on a population level, on people who look and sound and live like you, not just, a very Eurocentric, I hate to say it, but where the data is more representative of the community that you belong to.
Fascinating, and it really is kind of this description of the new world that you alluded to. I'll end one more question to Ali, and then I'll open it for a Q&A. There are very interesting questions in the Q&A, and I urge you to add some more and even put in our chat if you wish. Is this whole idea of direct-to-consumer biohacking, wearables, all this enormous amount of data? So what's going to happen is our hospitals going to be, is it Apple, Amazon? We talk about Dr. Google. So what does it go? What are your thoughts there? Maybe the three of us, Irene will be the only one with a job, and the three doctors won't have a job anymore because we'll be replaced by these smart bots that are more available. What are your thoughts, predictions, concerns in this kind of trend that you're starting to see?
But we probably have optimistic thoughts about it. I think we'll always see that in-person care. There's something about the laying out of hands. I did mission work at a third world country, and this grandmother walked miles just to have an American physician laying hands on her granddaughter. She wasn't concerned that she was sick. They just wanted that laying on of hands. It's still very important, those personal connections, because we're not just our biology, our microbiome, our O2 sat, and our complete blood count. Medicine, when practiced, I think to the best, is the bio, psycho, social, right? So it's not just my biology, but what social supports do I have? Where am I at? What's my frame of mind, my ability to then, even if you give me an actionable item, lots of actionable items that will show good outcomes that people still can't do. And that might have more to do with their psychosocial milieu than their biology. So I'm going to be optimistic that, great, we're going to get really good at the biology side of it. And if we have AI helping to do all that interpretation, then wonderful. I, as a physician, can spend more time of, tell me what this illness is like for you. Here's what these AI machines are kind of putting together and saying, how does that resonate with you? Here are the treatments they're thinking about. So we're going to have more conversation that are going to be more personal and tailored to the other, very important in that triad, our psychosocial model. When we first started using electronic health records in my practice, remember, go from paper to electronic, people said never use computers. We found that we were so much more efficient. Instead of seeing patients every 8 to 10 minutes for sick and every 20 minutes for physicals, we stretched out to a half an hour for physicals, 15 minutes for sick. Because we were more efficient, we could spend more time in conversation. And it's only when we started saying, yeah, they check this box and check that box and do this, and it add more and more data that was great for population health and for billing, but not good for the person sitting in front of me necessarily. So I'd love to see it where technology comes back around with some automation, that we spend more time as physicians having conversations with our patients. That's my take on it.
Yeah, well, definitely a holistic approach. It won't go away, and you're absolutely right. I want to start to address a couple of questions from the audience. One is in regard to remote care, and this is for the whole panel, but maybe let's start with Irene, who was talking about, places that are so remote that don't have internet access and have to transfer information with GSM packets. What type of care actually can be done with telehealth? Sometimes you need actually a healthcare professional to do something. So what conditions are good for remote virtual care, and what are not? I think we stopped hearing you. Can you unmute yourself,
yeah.
Irene?
Irene is muted.
Oh, there goes
Yes.
that famous time. Sorry, I was on mute. Like Ali said, we can't actually not have that physical interaction with doctors, But so we're talking about first-line consultation, right? First-line consultation where you're able to share your symptoms, and a doctor on the other side is able to say, do 1, 2, 3, 4, or go here, there, gets me 1, 2, 3, 4 tests. That type of situation. So first-line consultation, but also, you have that situation where, yes, I have gone to a facility, health facility. Again, I'll give the case of Africa, and I've done all the tests, and doctors can't tell me what's wrong. They want to refer me to a doctor in another country, whether it's South Africa, for Pan-African support, or India, which is where a lot of East Africans at least go to, and I have to travel all that way, take all my documentation, to get another, set of analysis and further tests, etc. So that point where, yes, I've seen a doctor, I've done all the tests, now I'm able to send them to Ali, and Ali can give me an opinion, and Samantha can also give me an opinion. Actually, wait a minute, the 5 of them from wherever they are in the world can look at my documentation and give me even a better opinion, So now we're talking about even better quality support. So it's not for everything, but first-line consultation, expert opinion and support, and as technology evolves, but that can also grow. But let's also talk about the issue of insurance, health insurance, for example, where it's a big challenge in Africa. People don't have access to health insurance because it's expensive. But with your health data now, in the future soon, we'll be able to offer micro insurance to the users of Africa Record, because against the data that we're collecting, it's no longer, the system can predict, the cost, or what is viable as a cost for that patient's usability. So the opportunities are really vast, but we cannot completely replace. We do need to take the test. And, if we talk about wearables in Africa, it will take us a while because of the expense. It will be difficult for the majority of the population to afford those wearables. So we will still need to get to that point where we can access physical facilities. But maybe what also this means is, with models like this, we're able to attract more resources so we can build the infrastructures in place. Yeah, because with data, we're able to bring in partners to say, okay, look at this location, these are the issues, this is what's happening, can we put a facility, so resource management, resource mobilization, bringing in partners from wherever to create some of these infrastructures, physical infrastructures that will provide extra support.
You bring a lot of important points. I saw Ali nod her head when you talked about payment and insurance. Can you share, Ali, in a few minutes, and then I'll have a final question here from the audience that I want to run by Samantha. But Ali, can you give just 2 or 3 minutes your thoughts about payers and insurance and the whole revenue cycle management ordeal that is going into healthcare?
Right. And I'm glad you mentioned Irene, because we can't leave that out of the picture. We can talk about the ideal healthcare world and we want to practice, but someone has to pay for it. And no one can work for free. We wish we could, and if we could, that would be great, but payment's a part of it. Someone asked a great question about what are the 5 things you would do, trying to kind of write it down, and I'm listening to Irene, and payments came third in it, because you just can't ignore that, of how we're handling how healthcare is paid for. So without getting into what it looks like in the United States, no matter where, even in Africa, you have to take that into account. Someone has to pay for it, pay for the wearables. How do you make it affordable, accessible, and enjoyable? And so I put things in that order. Begin with the end in mind. Start with what would the best experience look like for me as a patient and for me as a physician. And if I can get both of those right, and I'm sure part of that is access, just access, knowing that I'm giving great care, knowing that I'm getting great care. So keep going in those triads, and then I can make a living without having to worry about billing, and they can afford. Right. So keep going in that dyad all the way down, that I have access to my data, my physician has access to the data, and that your physician has access to tech, and I have access to tech. But that's still number 5. So let's start with what does the best experience look like? The payments are in there, Alex, but kind of third on the list.
Yeah, no, there's so much, and obviously we can talk another hour, all these things that we're talking about, and great questions are coming out from the audience. I'm just curious, and maybe end this conversation with Samantha. We've heard here different technologies, AI, blockchain, wearables, telehealth. We've heard things happening in urban areas and rural areas in the US and the UK and in Africa. The future, we'll look at how will it be like, if you could have to guess, who will adopt these technologies first? Will these, eventually be adopted in I would say the affluent economies, or will they be leapfrog in the lean economy? Where do you see the adoption easier, more helpful, more possible in your point of
I think it's going to be a little bit of both because there's different needs depending on the economy you live in. But I see it, okay, lean and fat economies, at some point they will converge and it would look a little bit similar. But like Irene was mentioning, a big priority is to have portability of health data, but without having access to internet. That's probably in a fat economy, that may not be a priority, but yet that is something a fat economy should look forward to in order to implement, because that means more access for all, right? Even for those in fat economies that don't have internet. But that probably won't be the top line priority in a fat economy. So it's we'll see. I think, I thought perhaps regulatory bodies would drive this, but in times of need, as we saw this year, things can shift and be relaxed in terms of rules, depending on how much we really need it as a society. Hence, telemedicine got pushed very quickly over the last 6 months, and it's been even before that, it was a slow trickle of adoption, and boom, every people that I would have never guessed, an 80-year-old colleague of mine is using telemedicine. Yes, there are glitches, but guess what? Everybody is now up to speed with it. So I think there has to be a really urgent need and changes from regulations and laws to really accelerate things a little bit faster.
Which then, in my opinion, makes me think that Africa, lean economy, as Alex would say, would probably adopt quicker. And reasons being, first of all, the problem is vast, right? And we are looking for solutions urgently. And also the mobile phone, all the way to dummy phones playing a role means adaptability is vast. Anyone with a phone is able to use it, but also, the payment, infrastructure in Africa, where mobile payment is changing how we seek solutions from our phones, makes it even more enticing and easy to use. So I think there will be a quicker adoption in Africa, and also the issue of regulation, Samantha, we're still not there yet, so there's a lot of room to test and do things where regulators are still thinking around what to do, with some of the things. So we have more leeway to effect some of the technologies that we are rolling out and launching.
Well, this has been an hour that passed really fast, a fascinating conversation. Leapfrogging is good. Maintaining optimal weight between fat and lean economies is also a good thing. And I want to thank you for a great conversation and for everything that you're doing to make healthcare better, accessible, and quality for everyone. So thank you so much.
Thank you, everybody.
Thank you.